Thank you very much, Chiara. Fantastic presentation, very meaningful discussion of your data presentations. I think we have time for a QA session with the participants and between also speakers. And let me take the privilege of the chair to ask straightforward to both of you. Do you think we should implement our attitude to perform liver biopsies in smaller tumors that are detected during screening, just to increase also the chances of early identification of mass-forming ICCA that can be 10% of the cases misdiagnosed using just a radiological approach? I think it's quite a debated issue, and I think that we are moving forward to have more liver biopsy done perform, not only in the patients who are prone to be transplanted, the few ones, of course, and but also in those who are going to be resected or ablated. Chiara and Alejandro, please, your thoughts on this.
If I may start.
Chiara first, of course.
Oh, sorry, no, Chiara, you first if you want to start.
I'm happy for Alejandro to start, as he's the pathologist, so he's the one who usually takes the decision. And then I give my recommendation.
I think, Massimo, the first, we have to separate the scenarios. First of all, it's not the same to talk about cirrhotic patients that in them we can apply the non-invasive diagnostic criteria, and those that are non-cirrhotic patients, and in them, obviously, biopsy should be performed, despite that the imaging is characteristic or suspicious of hepatocellular carcinoma. And accordingly, if the patient has not cirrhosis, my recommendation is obviously to take a biopsy, even if the imaging is potentially compatible with HCC. Probably the tricky scenario is the cirrhotic patients that you know, Massimo, that were able to apply the non-invasive diagnostic criteria based on the presence of hypervascularity in the arterial phase followed by washout. In cirrhotic patients, if we apply this strict criteria based on magnetic resonance and in CT scan, the probability to fail or to misdiagnose HCC and cholangiocarcinoma is anecdotal, and probably I will say that we don't need to take a biopsy to confirm the diagnosis. Probably what we see in the real practice is that patients that has been diagnosed with HCC, we have the confident diagnosis by imaging, and we treat them with TACE, with local regional therapies, or we are evaluating patients for liver transplantation, and in them they develop additional nodules that they are hypervascular, that they don't fit the profile for putting the diagnosis of HCC, but we assume that are HCC, and finally the patient is transplanted, and we analyze the explant, and it's not very rare to find anecdotically incidental intrahepatic cholangiocarcinoma within the liver. But when we have analyzed retrospectively the radiological findings of these nodules, I can tell you that those nodules, they did not accomplish the non-invasive diagnostic criteria for HCC. And therefore, my recommendation is, if there is not cirrhosis, obviously you have to take a biopsy. There is no discussion. If we have a cirrhosis and the nodule clearly display the non-invasive diagnostic criteria, there is not any clinical argument to take a biopsy to do the differential diagnosis of intrahepatic cholangiocarcinoma versus hepatocarcinoma. My concerns probably are based on the use of contact-enhanced ultrasound, that I think that there is still some room of misdiagnosis between HCC and cholangiocarcinoma. But this is just only my personal feelings and my comments.
Yeah, Alejandro, I want also to engage Chiara in this discussion. There is a growing rate of number of patients in whom a liver biopsy is not taken to a certain liver cirrhosis at the beginning. They start being suppressed with nuke for Hep B, or to be eradicated for Hep C with DAA, and in the end, playing the game with FibroScan, with NEAT, you're still wondering whether the patient has significant fibrosis or not. And if this patient develops a nodule, you miss a starting biopsy, you miss the opportunity to rule out cirrhosis or rule in cirrhosis in a very appropriate manner. And that specific case, I think the liver biopsy becomes mandatory. And my clear question to Chiara is, do you think, Chiara, that we miss reasonable and I would say, clear-cut opinions regarding liquid biopsies because we fail to do enough liver biopsies in the very initial cancers because we were trusting too much radiological diagnosis. So we do not have enough starting bench material in the early phases of cancer to validate the clinical utility of liquid biopsy. Both of you, Chiara first and Alejandro.
In reference to your last question, I think that we still don't have data. I mean, at the moment, the data that we have about liquid biopsy is for advanced disease. And we always have to think that, the liquid biopsy collects ctDNA that we can think is shredded from cancer cells that are in the circulation, potentially is also released by primary tumor, but we don't really have the data to understand and to know if small volume resectable tumors actually have a positive biopsy. I don't think that we really have any data to support that. And so, yes, I agree with you that definitely that is a comparison that we cannot talk about yet. In the extensive disease, I think that the liquid biopsy is good promising if we are looking at a specific subset of molecular alteration. If we can go back to the previous question, I kind of partly concur with Alejandro. I mean, definitely 100% if there is no cirrhosis, you have to go for a biopsy. If there is cirrhosis, I think we really need to move away from the fear that we've always had in biopsy patients, even if cirrhotic. Because I think that new data, I think we need to think why we never wanted to biopsy patients. Obviously, if they have to go through a transplantation, it's a different story. I mean, we can stay here and discuss forever. If we take that part out and we just consider a patient that would never be eligible for liver transplantation and has a cirrhosis, with a compensated cirrhosis for whom we are thinking about a systemic treatment, I guess that the complications from a liver biopsy are much less high than what we expected in the past. I mean, we have also done some studies here in UK through a national audit for HCC patients with cirrhosis. And if they have a good compensated cirrhosis, which are the patients we want to then treat, the complication rate is less than 1%. So given the increasing importance of molecular profiling in different tumor types, I think that it would be reasonable to start increase the number of liver biopsy. Because yes, I do agree that we are missing a lot of cholangiocarcinoma patients, and I tend to have many more referrals of patients that were thought to be HCC. Maybe they have a mixed component, or maybe the radiological aspects really depends also on the radiologist, and not always we have the possibility of applying always the same criteria.
Massimo, if I might add a comment from your question, you have put the scenario of patients that they are NAFLD with not clear advanced fibrosis. And again, I would like to deliver the clear message that the non-invasive criteria is just only valid for patients with well-known cirrhosis. And accordingly, in our clinical practice, if we have patients with NAFLD that we are not pretty sure that they are cirrhotics, or even patients with SBR, a long-term SBR, that now we don't have a clear proof that the patient is actually cirrhotic, we go ahead with the biopsy. And this is the message that I would like to deliver to the audience, that the non-invasive criteria should be just only implemented in those patients that they have a clear cirrhosis. The first point. Second point, also the non-invasive diagnostic criteria is very specific, but if it is applied in a very specific way, and we are very restrictive with the criteria. And then also in our clinical practice, if we have a patient that the imaging criteria is not met, then we go to biopsy. And just only to share with you that the BCLC will defend the non-invasive diagnostic criteria, but when we have analyzed retrospectively all of our patients in our clinic, I can tell you that more than 80% of our patients, they have an histological confirmation of HCC. First of all, because the non-invasive diagnosis criteria cannot be applied. Second, in some cases, we have done the diagnosis with imaging, but we have been go ahead with surgery or with transplantation and then we have confirmed the diagnosis with the surgical specimen. And when we go beyond to the systemic therapy, since we have now a lot of trials that they ask for histological confirmation, and then we have to do a biopsy for this investigational purposes. And again, in the real practice, even in our center, that we are very defendant of the non-invasive radiological criteria, we have more than 70-80% of patients with histological confirmation. And also we have patients in the advanced stage that if the imaging is clear, obviously we don't need the biopsy if there is not a trial that demand a biopsy. But also when we have patients at advanced stage that we have nodules that are not clearly compatible with hepatocarcinoma, we go with biopsy to discard cholangiocarcinoma or even another malignancy that can be mixed with hepatocarcinoma. And this is the message that I would like to share with the participants, that I trust in the non-invasive criteria, but obviously we have to apply it in a very restrictive way.
Thank you, Alejandro. Yes, please. I want to remind also the audience that they could text their questions as a chat. Yes.
I just have a question. From my understanding, the older ones know that the biliary tract cancer were an orphan disease. It means that those, tumors of the gallbladder and of the choledochus, they were seldom. And there was a problem to get enough patients for trials. And then ICC came, and this is always a retrospective diagnosis in resected patients, and they have been added, but you have a further disease. 80% of those tumors arise in cirrhotic liver. And oncologists don't like cirrhosis. They don't like it at all. But Chiara, you presented data. Also, there were some ICC in those trials, but most of them are FOLFOX. You don't use FOLFOX in cirrhotic patients. So these are extrahepatic tumors. So I would wish, and hear your opinion, just to separate those. Because, as Alejandro said, this is a retrospective diagnosis. You don't have lymph node. Then the lymph nodes are not taken out. Now they are learning that you may need biopsy, because if you go to operate, you want to get lymph nodes, and your lymph nodes examined. And if you have metastasis in the lymph node, then you have, of course, a worse prognosis. But you have, already a bad prognosis because the patient has cirrhosis. So you, oncologists, how do you like cirrhotic patients? How much?
Well, obviously, it depends on the level of cirrhosis. The clinical trials, they do include quite an interesting amount of intrahepatic cholangiocarcinoma. I would not say that they are only extrahepatic, and maybe the opposite, especially for targeted therapies. The level of cirrhosis, obviously, I have to admit, I don't see a huge increase in cirrhosis in my clinic, even though, yes, there is probably a 5% increase. But I think it really depends on the compensation, the level of compensation. And I have to be honest that there has been a change, I would say, from the oncology perspective, with the introduction of more treatment in the liver cancer field in general. If you think about HCC, there has been a much more relaxation from the oncologists to treat some cirrhotic patients. Probably all child 5 and 6, they are treated now with the same guidelines of the non-cirrhotic patients. For child big 7, I think, you do consider a few other factors. You have to consider other comorbidities. You have to consider how fit the patient is. And then sometimes I try in a little bit a lighter way and then escalate the treatment during time. And obviously, when we go to beyond, I don't think that is an area where we have evidence to treat them at this moment. But I wouldn't say that we are not considering the cirrhotic patients at the moment.
If I might add a comment, Giuliano, probably we have somehow of bias I'm a hepatologist, and probably I visit a lot of cirrhotic patients, and in my clinic, I have a proportion of cholangiocarcinoma appearing in cirrhotic patients, probably significantly much higher than Chiara or Juan Valle in Manchester. But I think that this is somehow a selection bias. My personal feeling is that since we are hepatologists, we are doing surveillance for the HCC, we have the chance to diagnose cholangiocarcinoma at a very early stage or even in early stage. And then when we review the data coming from hepatologists doing surveillance, and if we also review the data from surgeons doing surgery in patients with cholangiocarcinoma, the proportion of cirrhotic patients probably is significantly higher than the series of the cohort studies coming from the oncology departments, basically because those cirrhotics that they have advanced cholangiocarcinoma, in most cases, they are not submitted to oncologists because they have low platelets, decompensation, and the proportion of patients that are treated with chemotherapy are very, very small. If we go beyond and we go to the ENSCA database, has been recently published by Laura Izquierdo in Neuropathology, the proportion of cholangiocarcinoma in cirrhotic patients, I don't have the exact figure, but it was more or less between 10-20% of patients, they have an underlying chronic liver disease. And then if we put the big picture of cholangiocarcinoma in Europe, 80% of cholangiocarcinoma patients diagnosed in Europe are from patients that they don't have a chronic liver disease or a cirrhotic patients. Again, it depends on the scenario. As a pathologist, since I do surveillance for cirrhotic patients, I'm able to detect a huge amount of early cholangiocarcinoma. And then if you review my cohort of patients, I have a lot of very early cholangiocarcinoma that has been treated with radiofrequency, has been accidentally transplanted, or I have a large number of patients with a small cholangiocarcinoma, less than 5 centimeters, even less than 2 centimeters has been operated. If we move to the oncology department, probably the proportion of cirrhotic patients are significantly less. But again, if you put the big picture, Giuliano, I think that between 10-20% of patients with cholangiocarcinoma are cirrhotics. Most of the patients with cholangiocarcinoma are non-cirrhotics, and I will say with no clear chronic liver diseases. And this is the real picture of the whole population that we are treating in Europe.